Imagine a perfectly normal day. You're driving, walking, maybe just enjoying a quiet moment when suddenly, in an instant, everything changes. A crash, a fall, an unexpected impact. In that chaotic, terrifying blink, lives hang in the balance, and what happens next determines everything. This isn't just about, band-aids. It's about a highly specialized field, constantly evolving strategies, and the split-second decisions that truly save lives. Welcome to the Deep Dive, the show where we take complex topics, cut through the jargon, and really extract the most important nuggets of knowledge to make you truly well informed. We're your expert guides today, and our mission is to embark on a critical deep dive into the world of acute trauma management. We've got a comprehensive stack of sources from leading experts, a textbook chapter that is practically the Bible of surgery, and our mission is to unpack it all for you. We're going so deep today, you'll understand this information like an elite professional in the field. So what can you expect from this deep dive? Well, we're going to trace the fascinating and sometimes brutal history of trauma care. We'll dissect the intricate systems built to get the right patient to the right place at the right time. Then we'll break down the crucial first moments of assessment and intervention, both in the field and in the trauma bay. Before plunging into the specifics of managing injuries from head to toe, you're about to get a shortcut to truly mastering this vital area of medicine. Okay, let's unpack this. Trauma care isn't just a modern invention, is it? It has a rich, sometimes brutal history that has profoundly shaped it into what it is today. And interestingly, much of that shaping came from, well, the crucible of war.
You're absolutely right. Injury management has always been a core assignment for surgeons, throughout history. But what's truly fascinating here is how profoundly wartime has advanced the field. This acceleration is primarily due to the immense disease burden. The sheer volume and severity of injuries that conflict imposes. If we connect this to the bigger picture, many of the techniques, the organizational structures, even the philosophical approaches we now take for granted in modern civilian trauma centers, well, they have their direct roots on the battlefield, forged in necessity, really. Consider, for instance, the French and Indian War, way back 1754 to 1763. This era, though rudimentary by today's standards, gave us some of the earliest foundational understandings of basic wound healing processes. Concepts like wound contraction, differentiating between primary healing, where wounds close quickly, and secondary healing, where they heal from the bottom up, often with significant tissue loss. And the crucial appearance of granulation tissue and epithelialization. These were basic, but absolutely critical steps that move beyond mere observation to a sort of rudimentary understanding of biological repair. Then, the American Revolutionary War, 1775-1783, introduced concepts that, while they seem archaic now, marked a shift in medical thinking. We saw this concept of exhaustive therapy, which involved practices like bleeding, inducing diarrhea, vomiting, salivation, sweating, all aimed at purging the body of perceived toxins. Now, we understand these methods as harmful, counterproductive, often leading to dehydration and further physiological collapse. But the war did, crucially, spur the centralization of medical care for the first time on a large scale. And it led to the establishment of the very first medical schools. That was a monumental systemic leap, laying the groundwork for formal medical education. Fast forward to the American Civil War, 1861 to 1865. A brutal conflict, unprecedented scale of battlefield casualties. It saw a significant and life-saving shift from secondary to primary amputation, meaning surgeons increasingly opted to amputate a severely damaged limb immediately, rather than waiting for infection to set in. That drastically reduced mortality from sepsis. It also saw the early, though often crude, use of topical antiseptics to prevent infection. And importantly, the first documented whole blood transfusions, though these were direct and often risky. We also saw the development of specialty hospitals, dedicated facilities for specific conditions like eye ear, orthopedics, hernia repair foreshadowing modern specialized care. And significantly, extremity traction splitting emerged, offering a more stable way to manage severe limb fractures. World War I, 1914-1918, characterized by trench warfare, high-velocity shrapnel injuries. It brought major advancements in managing penetrating abdominal trauma. We saw the widespread adoption of laparotomy surgical incision into the abdomen to explore and repair injuries. This era also standardized wound debridement, the removal of dead or contaminated tissue, and delayed closure, where wounds were left open for a period to prevent infection before being surgically closed. Critically, this period gave us the first blood bank, systematizing the collection and storage of blood, along with the early use of plasma, the liquid component of blood and crystalloids, salt solutions for resuscitation to combat shock. World War II, 1939-1945, continued this trajectory. We saw further refinement in techniques like guillotine amputation with delayed primary closure. and the exteriorization of colon injuries, where damaged sections of the large intestine were brought outside the body temporarily to reduce abdominal infection. This is also when highly mobile surgical teams became a reality, greatly improving rapid access to specialized care right on the front lines. And notably, early descriptions of multi-organ dysfunction after severe injury began to emerge, laying the groundwork for understanding systemic responses to trauma. The Korean War, 1950-1953, marked breakthroughs in vascular surgery, pioneering techniques for limb salvage that were previously unimaginable, directly preventing countless amputations. This conflict also saw the clear recognition of hypovolemic shock caused by massive blood loss as a distinct entity, allowing for more targeted resuscitation. And of course, the iconic Mobile Army Surgical Hospital, MASH units, truly revolutionized rapid surgical intervention and forward-deployed definitive care, setting the stage for rapid evacuation and treatment. The Vietnam War, 1955-1964, introduced groundbreaking innovations like aeromedical transfer via helicopters, dramatically shortening transport times from the battlefield to definitive surgical care. This practice gave rise to the now ubiquitous concept of the golden hour, emphasizing that critical interventions within the first 60 minutes of injury can drastically improve outcomes.
Right, that idea that time is absolutely critical.
Exactly. And sulfamylon, a topical antimicrobial, was introduced for burn care, preventing infection and severe burns. And importantly, there was the early recognition of a severe lung injury, now known as acute respiratory distress syndrome, ARDS. Back then, it was chillingly referred to as Da Nang lung, due to its prevalence among wounded soldiers. Most recently, Operation Enduring Freedom in Iraq, starting in 2003, has been a crucible for developing modern damage control resuscitation and highly efficient integrated civilian military trauma systems. Concepts we'll definitely dive deeper into later. And, quite interestingly, it saw the reemergence of tourniquet use, which had fallen out of favor for a long time due to concerns about limb damage. Across all these conflicts, you can see consistent improvements emerged in wound management, resuscitation strategies, and the fundamental systems of care. What's also fascinating is the reciprocal relationship between military and civilian advancements. Military advancements have profoundly influenced civilian care, and vice versa. Civilian training of military providers, research in civilian settings on hemostasis, stopping bleeding, and damage control techniques. These have saved countless service personnel on the battlefield.
So given that rich and often brutal history, how did all these lessons and evolving practices actually coalesce into a distinct surgical field, what we now call traumatology? How did it become its own entity, separate from general surgery, with its own structure and oversight?
That's a critical evolutionary step. Traumatology truly matured significantly over the last century, mainly through systematic organization and oversight. The American College of Surgeons, ACS, formed way back in 1913, initially appointed a committee in 1922, chaired by Charles L. Scudder, just to report on fracture management. But this focus, initially narrow, soon broadened dramatically. In 1949, this committee formally evolved into the Committee on Trauma, COT, recognizing the undeniable need for formal, comprehensive oversight of all injury care, extending far beyond just fractures. The COT has been instrumental globally in advancing trauma care through several key initiatives. They published foundational texts like Early Care of the Injured, which guided practitioners. They developed the ubiquitous Advanced Trauma Life Support, ATLS course, which we'll absolutely discuss in detail later. That course has now trained over 1 million students in 86 countries, standardizing the initial approach to trauma care worldwide.
Wow, over 1 million. That's incredible reach.
It really is.
Yeah.
The COT also established rigorous programs for the verification of trauma centers, ensuring they meet specific criteria. Perhaps most critically, they've been the driving force behind the development of comprehensive trauma systems, aiming to improve access to optimal care for every single injured patient. One of the most effective ways the COT has operated is through the creation of state-level divisions. These state committees are frequently involved in 4 core high-impact activities. First, they lead trauma system development, including creating precise triage documents that guide patients to the appropriate facility, thereby maximizing local resources. Second, they spearhead injury prevention initiatives, working to reduce the incidence of trauma itself, which is, the ultimate goal.
Sure, prevention is always best.
Absolutely. Third, they oversee the maintenance of statewide trauma registries, collecting invaluable data on injury patterns and outcomes. And finally, they are at the forefront of performance improvement efforts, continuously assessing and refining care quality to ensure best practices. This ensures care quality is constantly assessed and refined. To further standardize how trauma centers define appropriate structure, process, and outcome, the COT first created the resources for the Optimal Care of the Injured Patient Reference Manual in 1976. It's widely known in the field as the Orange Book.
Orange Book, okay.
Right. This manual is now freely and electronically accessible in its sixth edition, with an update from 2019. It provides a foundational guide for trauma centers globally. The COT also developed and maintains the National Trauma Data Bank, NTDB, which is the largest database of trauma ever assembled. It currently contains more than 7 million patient records from 747 trauma centers, providing invariable, up-to-date information on specific injuries and outcomes. This data is regularly referenced by professionals, including in the source material we're diving into today, to inform best practices in research. Beyond the COT, several other professional organizations have emerged, all with the primary goal of improving trauma care, reflecting the growing specialization of the field. The American Association for the Surgery of Trauma, AAST, founded in 1938, is the oldest and largest of all trauma professional organizations. Their annual scientific conference has evolved into the annual meeting of the AAST and Clinical Congress of Acute Care Surgery, reflecting the inclusion of emergency general surgery as a critical component of acute surgical care. The AST has also been the lead organization in developing the acute care surgery training paradigm, which now includes advanced education in trauma, emergency general surgery, and surgical critical care. Since its inception in 2008, 21 centers now provide this specialized, elite-level training. Partnering academic organizations include the Eastern Association for the Surgery of Trauma, EAST, and the Western Trauma Association, WTA. Both groups actively promote the exchange of cutting-edge scientific knowledge in trauma care. They contain active multi-institutional trial committees that conduct critical research. And they focus on developing evidence-based practice management guidelines, which are vital for standardizing best practices across the country. Furthermore, the American Trauma Society, ATS, founded in 1968, has been instrumental in injury prevention and trauma systems development, actively advocating for injured patients and promoting trauma-related legislation. Finally, multidisciplinary organizations like the Orthopedic Trauma Association, the American Association of Neurological Surgeons, and the Society of Trauma Nurses represent the diverse team members, from surgeons to nurses to neurosurgeons, all dedicated to improving injured patient care. This truly underscores the comprehensive and collaborative nature of modern trauma care.
So with all these organizations and historical shifts, it really points to one overarching goal, the development of a cohesive trauma system. But for the listener, how does that actually work on the ground? What's the practical impact of having such a system in place, getting the patient from the scene to the best possible care?
That's the perfect question, because the ultimate goal of a trauma system, at its most basic and profound level, is to get the right patient to the right place at the right time. This foundational principle underpins every aspect of system design, from dispatch to rehabilitation. We know that trauma outcomes are highly dependent on injury geography. Regions with organized approaches to care, what we call trauma systems, consistently maximize meaningful patient recovery. The ideal trauma system isn't just about the hospital. It actually includes the entire continuum of care, beginning with injury prevention initiatives encompassing pre-hospital care, acute hospital services, post-injury rehabilitation, and ongoing research to continually improve. Early on, trauma care in the U.S. was primarily centered on large academic hospitals, operating as what were called exclusive trauma systems. In this model, all patients, regardless of injury severity, were transported to these major trauma centers. While this approach was certainly beneficial for the severely injured, it proved highly inefficient for minimally injured patients. It wasted precious local resources and led to unnecessary transfers that took valuable time and ambulance resources. Data soon emerged, showing similar outcomes and improved efficiency for less severely injured patients when they were managed closer to home. The solution, and our current model, was the development of the inclusive trauma system, as beautifully illustrated in Figure 17.1. This model identifies specific roles for all hospitals within a region, ranging from critical access hospitals in rural areas to the large Level 1 and Level 2 trauma centers in urban hubs. Injured patients are guided by specific, well-defined triage protocols, which direct them to the facility most appropriate for their specific injury severity. This tiered approach might still require transfers to the most complex cases, but it crucially ensures that most patients receive appropriate treatment within their local network, minimizing unnecessary travel and optimizing resource utilization. The benefits are clear. It dramatically reduces the wastefulness of medical resources and allows for appropriate high-quality care to be delivered efficiently within the community.
Okay, so it's like a network, tiered based on capability.
Precisely. To visually represent this, Figure 17.1 shows how the most severe, life-threatening injuries are directed to Level 1 centers, which have the highest level of comprehensive resources. Moderate to severe injuries go to level 2 centers, which also provide a high level of specialized care. Minor to moderate injuries can often be handled by level 3 or level 4 centers, which serve as crucial community access points. And minor injuries, while still requiring acute care, can go to other acute care facilities within the system. This structured, tiered approach maximizes resource utilization across an entire region. The components of a comprehensive inclusive trauma system are complex and interconnected, as outlined in Box 17.2. These essential elements include robust injury prevention efforts, highly skilled pre-hospital care teams, precise triage protocols, robust communication systems ensuring seamless information flow, efficient transportation networks, ground and air, acute care facilities with varying capabilities, rigorous trauma center designation and verification processes, comprehensive post-acute care and rehabilitation services, continuous performance improvement initiatives, ongoing education and outreach programs, and, crucially, supportive legislation. You can truly see how intricate and interconnected this is. Coordinating all these elements to function as a seamless whole is a monumental undertaking.
That truly sounds like a monumental undertaking. What was the absolute catalyst for developing these complex integrated systems here in the U.S.? What was the defining moment that said, we have to do this?
The absolute genesis of modern trauma systems in the United States was a landmark report from the National Academy of Sciences in 1966, powerfully titled, Accidental Death and Disability, the Neglected Disease of Modern Society. This report was a real wake-up call. It meticulously laid bare the significant public health burden of injuries, highlighting them as a major yet overlooked cause of death and disability. This powerful report directly led to pivotal congressional legislation, the National Highway Safety Act of 1966. This act specifically allocated federal funding for the care of individuals injured in motor vehicle accidents, recognizing the sheer volume of trauma arising from this source. States like Maryland, Illinois, and Florida were early proactive adopters, leveraging this federal initiative to implement state trauma infrastructures about 40 years ago. Their groundbreaking efforts demonstrably reduced mortality rates, providing concrete, undeniable evidence that organized systems worked, and worked significantly better than fragmented care. Despite this early progress, injury remained an ongoing national issue. The critical follow-up report, Injury in America, a continuing public health problem, published in 1985, reinforced the continued need for action and further systemization. This relentless advocacy led to the National Center for Injury Prevention and Control being subsequently installed into the Centers for Disease Control and Prevention, CDC, elevating injury prevention to a formal public health mandate. Congress then legislated the Trauma Care Systems Planning and Development Act of 1990, which formally addressed the need for and provided crucial federal funding for new or revised state trauma systems across the country. Further advancement occurred in 1992 when the Health Resources and Services Administration released the comprehensive Model Trauma Care System Plan. This document provided a standardized template for states, applying a robust public health disease-based approach to trauma care. It identified three critical functions for truly effective trauma systems. First, epidemiological assessment to understand the precise scope and patterns of the injury problem. Second, policy implementation for public protection, ensuring consistent standards. And third, the provision of high-quality, well-regulated care, guaranteeing patient safety and optimal outcomes. This comprehensive approach was later revised in 2006, highlighting its continuous evolution and adaptation based on new data and understanding.
That's a clear legislative and organizational path. But the real question for our listener is, did these systems actually make a measurable difference in saving lives once they were implemented across the country? Was the effort worth it?
Absolutely. The evidence is clear and compelling, definitively demonstrating the life-saving impact of these organized trauma systems. One of the most significant and influential studies was the National Study on Costs and Outcomes of Trauma, NSCOT, conducted in 2006. This was a large epidemiological study, meticulously supported by the CDC, specifically designed to evaluate variations in care and outcomes between designated trauma centers and non-trauma centers. NSCOT included a massive cohort of over 5,000 patients from 69 hospitals across 12 states. Its findings were profound and left no doubt. It definitively established that patient outcomes are significantly improved when care is provided at a designated trauma center compared to a non-trauma center. After carefully correcting for confounding factors like injury severity, the study found that care at a trauma center was associated with a 20% reduction in hospital mortality and a 25% reduction in one-year mortality.
25% reduction in one-year mortality. That's huge.
It's massive. It means 1 out of 4 patients who might have died at a non-trauma center were still alive a year later because they received care at a trauma center. At a broader system level, Nathans and colleagues in 2000 also powerfully demonstrated the value of a coordinated regional response to injury. They conducted a comprehensive study of 400,000 patients over a 17-year period from 1979 to 1995. This time frame was precisely when trauma systems were actively being established and optimized across the country. Their meticulous research showed that the development of a comprehensive trauma system resulted in an 8% reduction in overall mortality over that 15-year period. These studies collectively underscore that organized, systemic approaches to trauma care are not just theoretical constructs. They are real, tangible, and demonstrably save lives on a wide scale.
That's incredibly significant. But given our diverse geography and population density across the U.S., is there truly a one-size-fits-all approach to building these trauma systems? Surely a rural area faces different challenges than a bustling city.
You've hit on a critical point. There isn't a one-size-fits-all approach, and successful trauma systems must be carefully tailored to both rural and urban settings, recognizing their unique challenges and resource availability. To address this complexity, the CIT developed the Needs-Based Assessment of Trauma Systems (NBATS) tool in 2015. This sophisticated tool was designed to assist states and regions in the strategic designation or creation of new trauma centers, ensuring they are placed precisely where they can provide the most benefit and fill existing gaps in care. NBATS uses a meticulous point value system that evaluates 6 key categories within a given trauma service area. It considers the local population density, the median transport time to an existing trauma center, the level of community support and infrastructure, the number of severely injured patients discharged from non-trauma facilities, the existing number of Level 1 centers, and the number of severely injured patients already evaluated at existing centers. This comprehensive assessment aims to provide a data-driven rationale for resource allocation. Given initial complexities and observed discrepancies, like overestimations in rural areas and underestimations in urban areas, a second refined version, NBATS 2, was created in 2018. This update incorporated cutting-edge predictive geospatial modeling to further refine the assessment, making it far more accurate and nuanced. A significant benefit of this updated tool is its ability to assess how adding a new trauma center might affect the volumes of established centers and their payer mixes, which is crucial for financial viability and equity. These sophisticated tools continue to evolve with our understanding of optimal trauma system structure, providing you valuable insight into how best to organize and optimize care in each unique region, moving beyond simple demographics to deeply integrate geographic and resource realities.
So now that we understand the intricate architecture of these trauma systems, a fundamental question emerges. How do medical professionals actually quantify injuries and communicate their severity in a standardized way? It seems like you'd need a common language to accurately describe what's happening to a patient, especially when handing off care or doing research.
That's exactly. Concurrent with the development of trauma systems, the need for a reliable and universally understood method of injury comparison became absolutely critical. We simply cannot analyze outcomes, compare treatment efficacy, or even effectively triage patients without a common, precise language. To address this, injury scoring systems generally fall into 2 main types: those based purely on anatomy, the physical damage, and those based on physiology, the body's response to that damage. First, let's delve into anatomic systems. The Abbreviated Injury Scale, or AIS, first described back in 1971, is the most widely used anatomic system for classifying injuries globally. It provides an incredibly precise and granular way to describe injuries. Injuries are characterized by a highly specific 6-digit taxonomy. It identifies the body region affected, the specific type of anatomic structure involved, and even more granular specific anatomic details. For example, the AIS first digit code specifically identifies 9 broad body regions, as seen in Table 17.1. 1 for head, 2 face, 3 neck, 4 throat abdomen, 6 foot and spine, 7 upper extremity, 8 motor lower extremity, and 9 months unspecified. That immediate first digit provides a clear, concise location. Perhaps even more widespread in its utility is the AIS severity code, often called the post-doc code. This 7th digit in the AIS taxonomy specifically describes the severity and potential risk of death for each individual injury. It ranges from 1, minimal severity, like a minor bruise, to 6, presumably fatal, indicating a catastrophic injury. These codes are frequently used by professionals to group injuries into cohorts, meaning similar patient groups, and to rigorously compare treatment outcomes across different studies or institutions. The Association for the Advancement of Automotive Medicine rigorously refines the AIS to ensure it remains current and accurately characterizes injuries as our understanding evolves. The AIS forms the fundamental building block for other scoring systems that can better account for the overall severity of multiple combined injuries in a single patient, which is common in polytrauma. In 1974, Baker and colleagues introduced the Injury Severity Score, or ISS. This score is derived from the AIS and is calculated by summing the squares of the AI severity codes for the three most severely injured body regions in a patient. So, for example, if a patient has a severe head injury, AIS 5, a serious chest injury, AIS 4, and a moderate abdominal injury, AIS 3, their ISS would be 5 squared plus 4 squared plus 3 squared, so 25 plus 16 plus 9, which equals 50.
Okay, so it gives one number for the overall severity.
Exactly. The ISS ranges from 1 to 75. It categorizes overall injury severity into groupings: minor, 9, moderate, 916, serious, 1625, and severe, 25. The ISS is widely used to quantify the overall burden of injury, providing a singular metric for research and prognosis. As a further development, the Organ Injury Scale, or OIS, released by ACE, has been incorporated into recent AIS versions. The OIS introduces granular injury grades for specific organs, adding even greater detail and delineating severity, which has been validated with the NTDB for its strong association with morbidity and mortality risk. In addition to these anatomic systems, we have physiologic systems. These scales are critically important because they reflect the body's real-time response to injury, making them extremely useful for immediate decision-making. Most commonly used is the Glasgow Coma Scale, or GCS, which quantifies level of consciousness and neurologic function. As shown in Table 17.2, GCS scores range from 3 deep coma to 15 fully awake. It's composed of 3 measures: eye-opening, verbal response, and motor function. The motor score alone, in particular, has been found to be a powerful predictor of outcomes after traumatic brain injury, TBI. Another well-studied physiologic scoring system is the Revised Trauma Score, detailed in Table 17.3. This score provides a rapid assessment by incorporating GCS, systolic blood pressure, and respiratory rate. This makes it invaluable for research and critical triage decisions in the pre-hospital environment.
So once medical professionals have these standardized ways to describe injuries, what's the very next step? The patient is often still in the field at this point, right, far from the trauma center. What happens there in those critical first moments?
Precisely. That's the absolutely critical pre-hospital phase of care, the bridge between injury and definitive treatment. The ultimate overarching goal of the pre-hospital system is elegantly simple but profoundly impactful. Move the patient to a location capable of providing definitive injury management as quickly and safely as possible. Time is of the essence, that concept we often refer to as the golden hour in trauma care, emphasizing that critical interventions within the first 60 minutes after severe injury can significantly improve survival and recovery. The pre-hospital team paramedics, EMTs, plays an integral and highly skilled role, guided by 4 key priorities they must execute with speed and precision. First, evaluate the scene for safety. Second, perform an initial rapid assessment to identify immediate life threats. Third, make the crucial triage transport decision where the patient needs to go. And fourth, initiate critical life-saving interventions and transport the patient simultaneously. During that initial assessment, the ABC mnemonic guides them: A, airway with spine protection; B, breathing, assisted if needed; and C, circulation, hemorrhage control, resuscitation.
This structured approach leads to what we call the load-and-go approach, a philosophy where essential pre-hospital interventions are provided while transporting, minimizing scene time delays. Recent research powerfully underscores this time sensitivity. A large NDDD review by Chen et al. In 2019 showed that trauma patients with pre-hospital hypotension, SPP90, GCS8, and non-extremity firearm injuries have significantly higher mortality with increasing pre-hospital time. This evidence unequivocally shows that immediate departure from the scene is paramount for these critically injured patients. Identifying where to transport the patient is guided by incredibly well-defined evidence-based protocols. Figure 17.2 illustrates the field triage decision scheme, developed by the CDC, and a cornerstone of ATLS 10th edition. It's a robust 4-step process, evaluating physiological status, anatomical injuries, mechanism of injury, and special considerations. Step 1. Physiologic. This is the most urgent filter. GCS E13, SBP, 90mm Hg, or RR10 or 29, or need for ventilatory support. If any positive, transport directly to the highest level trauma center. Step 2. Anatomic.
If step 1 is negative, assess for severe anatomic injuries. This includes penetrating injuries, head, neck, torso, proximal extremities, chest wall instability, 2 proximal long bone fractures, crush a glove, mangled pulseless extremity, amputation proximal to wrist ankle, pelvic fractures, open depressed skull fracture, or paralysis. If positive, also transport to the highest level trauma center. Steps 1 and 2 identify the most critical patients. Step 3, mechanism of injury. If steps 1 and 2 are negative, look at the mechanism. Falls, adults 20 feet, children or 10 feet, high-risk auto crash, intrusion O12 and occupant 18 at any site, ejection, death in same compartment, high-risk telemetry, Auto versus pedestrian bicyclist, thrown run over, or 20 mile/hour impact, motorcycle crash, 20 mile/hour. If positive, transport to a trauma center, though maybe not the highest level, based on local protocol. Step 4, special patient system considerations. Finally, consider specific patient factors.
Older adults, 55 years, SBP 110 might mean shock 65, low-impact falls cause severe injury, children, pediatric capable centers, anticoagulous bleeding disorders, head injury high risk, burns, triage to burn facility, or trauma center if other trauma higher risk, pregnancy 20 weeks, and EMS provider judgment. If positive, transport to a trauma center or capable hospital. Consult medical control. The goal for most agencies is less than 15-minute scene time.
Those triage decisions are incredibly rapid and high stakes. So once a patient is identified as critical, what are the most crucial immediate interventions the pre-hospital team might perform right there on the scene to stabilize them before transport, beyond just the basic ABCs?
The most immediate concerns, beyond initial assessment, are indeed advanced airway management and rigorous hemorrhage control. These directly mitigate the leading causes of preventable trauma mortality. For pre-hospital airway management, the initial concern is securing an open airway, especially with altered consciousness or facial injuries. The gold standard is endotracheal intubation, placing a tube directly into the trachea. This is typically done using rapid sequence intubation, RSI, or drug-assisted intubation, DAI, using medications for sedation and paralysis. It's absolutely crucial to always assume spinal injury and maintain precautions, collar, manual stabilization, during any airway maneuver. Now, the utility of advanced airway management, specifically intubation in the field, has been, debated. Some studies link pre-hospital intubation to increased mortality versus non-invasive techniques. Others show benefit, especially for severe TBI outcomes. It's a complex decision weighing technical challenges and physiological consequences, like cardiovascular collapse and hemorrhagic shock, against the benefits of airway protection and oxygen delivery. As a critical alternative, blind insertion supraglottic airway devices, like LMA King LTD, are common and valuable as a bridge, especially when intubation is difficult. Regardless, elite pre-hospital personnel need skills at all levels, from basic maneuvers to advanced airways while rapidly transporting. For pre-hospital hemorrhage control and resuscitation, uncontrolled hemorrhage is by far the primary cause of preventable death. Stopping bleeding is paramount. Direct pressure remains the mainstay initial method. However, tourniquet use has seen a dramatic resurgence, especially for life-threatening extremity trauma, as shown in Figure 17.3. They were less used due to nerve muscle injury concerns, but military experience and device advances showed clear benefit. Recent civilian studies now report a mortality benefit.
The Stop the Bleed campaign, right?
Exactly. ACS initiative to instruct laypeople. Tourniquets are now standard equipment for most pre-hospital agencies. Concurrent with hemorrhage control, shock requires immediate resuscitation. Prior studies definitively show large volume crystalloid resuscitation, like saline, is actually detrimental, worsening acidosis, coagulopathy, edema. Blood products are superior. Gayet et al. 2019 found PRBCs with plasma gave the greatest survival benefit in helicopter transport in shock patients, followed by plasma alone, then PRBCs alone. Crystalloid increased mortality incrementally by dose among those needing blood.
So less saline, more blood products if possible.
That's the direction. Though more at all. 2018 found no survival benefit with plasma versus crystalloid in a ground ambulance study. This suggests pre-hospital plasma might benefit moderate transfusion needs most, not necessarily massive transfusion patients. Logistical challenges: supply, storage, cost limit pre-hospital transfusion currently. Many agencies use mixed crystalloid product resuscitation based on local resources.
So the pre-hospital team has made those critical decisions and interventions, and now the patient arrives at the trauma bay, that high-octane environment in the emergency department. This is where the ATLS course, the Advanced Trauma Life Support, really comes into play, right? That structured, systematic approach to initial care. Tell us how that unfolds for an elite professional.
Precisely. The Advanced Trauma Life Support, ATLS course, is absolutely the bedrock here. It's the single most standardized and widely adopted approach globally. Since 1980, ATLS has instructed over 1 million students in 86 countries. It provides a structured, systematic framework for rapidly identifying and immediately addressing life-threatening conditions, ensuring nothing critical is missed in the chaos. ATLS conveys 3 critical core concepts that profoundly enhance a provider's ability to manage injured patients. 1. Treat the greatest threat to life first. Prioritize interventions addressing immediate life threats over less urgent ones. Stop massive bleeding before splinting an arm. 2. Lack of definitive diagnosis should not delay urgent treatment. Don't wait for all the answers. If you suspect a tension pneumothorax, treat it based on clinical signs. 3. Initial detailed history is not essential to begin evaluation. Life-saving interventions take precedence over a lengthy history, which can be gathered later. Following these principles, ATLS prescribes a defined order of assessment, the primary survey, using the mnemonic ABCDE, as shown in Figure 17.4, A. Airway in cervical spine protection. Ensure breathing, protect the neck. B. Breathing. Assess ventilation, identify lung chest tissues. C. Circulation. Identify and control hemorrhage, manage shock. D. Disability or neurologic condition. Quick assessment of brain spinal cord. E. Exposure and environmental control. Fully exposed patient, prevent hypothermia. The primary survey is rapid, systematic, and crucially repeatable anytime the patient's condition changes. It's a robust tool to identify life threats and direct effort immediately.
Let's dive into each of those primary survey steps, starting with A. Airway and cervical spine protection. What's the immediate assessment? What defines an adequate airway here? And how do we protect the spine simultaneously?
Airway status is assessed immediately, within seconds of arrival. The most meaningful information often comes from eliciting a verbal response. The ability to speak clearly usually indicates an adequate protected airway and intact mental status. Conversely, no speech or garbled speech suggests either mental status depression or airway obstruction, blood, vomit. Both demand aggressive airway management. Further indicators of compromise include noisy breathing, gurgling, stridor, severe facial trauma, or patient agitation, which can paradoxically signal hypoxia. Adequacy and need for control must be determined in seconds. Frequent reassessment is paramount. Concurrent and equally vital is cervical spine protection. Until ruled out, assume all injured patients have a vertebral column injury. Maintain precautions. This is critical during any head-neck manipulation for airway management. Measures include a rigid cervical collar and the log roll technique for movement. The anterior collar can be temporarily removed for airway exposure, but absolute manual inline stabilization by an assistant is required then. Rigid, long spine boards are useful for transport, but remove ASAP in the bay to prevent pressure wounds.
When the airway is inadequate or at risk, a definitive airway must be established. For most, this means oral endotracheal intubation via RSI or DAI, as per ATLS 10th edition. While preparing, adjuncts like oropharyngeal and nasopharyngeal airways help maintain patency during pre-oxygenation. The procedure involves a sedative and a fast-acting neuromuscular blocker for maximal glottic visualization. Direct laryngoscopy and intubation follow, avoiding cervical spine motion. Confirmation involves chest auscultation, end-tidal CO2, and chest X-ray. Experienced airway personnel are critical. In difficult airways common in trauma, adjuncts are invaluable. The gum elastic bougie assists placement with limited vocal cord view, acting as a guide wire. Meta-analysis shows equivalent success to stylet, though studies are small heterogeneous. Video-assisted laryngoscopy provides an indirect monitor view, potentially mitigating challenges. Data on first-pass success conflict. Utility depends on provider familiarity. Blind insertion airway devices, LMA, CombiTube, King LTD, are alternatives if intubation fails. They occlude the esophagus, allowing ventilation down the trachea, a vital bridge.
When other approaches fail, or the patient can't be oxygenated between attempts, prepare for an urgent surgical airway, cricothyroidotomy, before irreversible deterioration. A cricothyroidotomy is rapid, 3 steps. 1. Spread tissues over the cricothyroid space with non-dominant hand to stabilize trachea. 2. Vertical midline incision, thyroid cartilage to cricoid. 3. Transverse incision of cricothyroid membrane, insert 6-0 ET tube or tracheostomy appliance. Frequent palpation guides dissection, avoids lateral neck structures. Avoid advancing the tube past the carina, confirm position immediately. Patients with suspected laryngeal injury may need formal tracheostomy in the OR, as cricothyroidotomy might be ineffective or harmful.
Once that critical airway is secured, the next vital step is B for breathing. How is that evaluated in the trauma bay, and what are the immediate life-threatening concerns an expert must rapidly identify and address?
Correct. After airway, breathing is evaluated by observing chest movement, auscultating breath sounds bilaterally, and measuring oxygen saturation. Limited effort, shallow breathing, or dyspnea signals need for ventilatory support and rapid chest assessment. Lung or chest wall compromise can be rapidly fatal. Several ventilatory problems require immediate intervention. Attention pneumothorax. Air enters pleural space, can't escape, collapses lung, shifts structures, causes respiratory deterioration, often unstable hemodynamics or cardiovascular collapse. Its clinical diagnosis, treat before X-ray. Signs, tracheal deviation away from injured side, unilaterally absent diminished breath sounds, cardiopulmonary compromise. Treatment, rapid thoracic decompression via needle thoracostomy or definitive tube thoracostomy.
So you act purely on suspicion there.
Absolutely, waiting for X-ray can be fatal. Another critical issue, massive hemothorax. Large blood accumulation, 1,500 milliliters in pleural space. Requires immediate tube thoracostomy to evacuate blood, re-expand lung, identify bleeding source. Finally, flail chest with pulmonary contusion. A segment of chest wall moves paradoxically. The associated lung contusion, bruising, is the biggest physiological insult, impairing gas exchange. Often needs aggressive mechanical ventilation, typically with elevated PEEP to keep alveoli open. Avoid repeated ventilator disconnections to maintain PEEP.
Okay, airway and breathing secure.
Yeah.
Then we move to C, circulation. This is often where the biggest, most immediate threat to life lies in trauma, isn't it? Rapidly identifying and controlling bleeding is paramount.
Most certainly. The primary goal of cardiovascular assessment is determining presence-absence of shock and identifying its cause. ATLS defines shock clinically as evidence of end organ hypoperfusion on physical exam. Organs aren't getting enough blood oxygen. Box 17.3 lists signs: agitation, confusion, brain, tachycardia, heart, tachypnea, lungs, diaphoresis, skin, cool mottled extremities, weak distal pulses, decreased pulse pressure, decreased urine output, kidneys, and hypotension, often late sign. Crucially, patients can be in shock before hypotension due to compensatory mechanisms. By far, the most common cause in trauma is hemorrhage. Acute blood loss must be ruled out first. We classify hemorrhagic shock into 4 classes, table 17.4, based on blood volume loss and physiological response. Class 1, 15% loss, 750 ml. Vitals mostly normal, maybe slight tachycardia. Class 2, 15-30% loss, 750-1500 ml. Mild tachycardia, 100-120, normal BP, narrowed pulse pressure, slightly faster breathing, 20-30, maybe anxious. Class 3, 30-40% loss, 1,500-2,000 ml. Significant instability, HR120, SPP90, tachypnea, altered mental status, urine output drops. Transfusion usually needed. Class 4, 40% loss, 2,000 ml out.
Severe shock, profound hypotension 70, tachycardia 140, minimal urine output, severe mental status changes, lethargy unresponsive. Needs massive transfusion. This framework helps quantify severity and predict resource needs quickly. Upon recognizing shock, ATLS recommends immediate IV access. 2 large bore, short peripheral IVs, ideally antecubital, or intraosseous needle, or a central line if needed. Initial resuscitation. Rapid 1-liter bolus of warmed crystalloid, for example, lactated ringers. Patients failing to respond appropriately, vitals don't improve or worsen, transition immediately to product-based resuscitation. Blood products. This is crucial. Progressive crystalloid beyond 1.5 liters significantly increases death risk by worsening the terrible triad: coagulopathy, acidosis, hypothermia.
So the old pour in the saline approach is out.
Definitely for uncontrolled hemorrhage. It dilutes clotting factors and worsens acidosis. Concurrent with resuscitation, rapidly screen for life-threatening blood loss sources. 5 major locations: chest, abdomen, retroperitoneum, pelvis, and long bone fractures. External loss and long bone fractures are identified on exam, managed with pressure and splinting. Adjunctive imaging during primary survey is vital for internal bleeding. X-rays: chest for hemothorax, pelvis for fractures, notorious for massive bleeding. Focused abdominal sonography in trauma, fast scan. Rapid ultrasound for intraperitoneal fluid, presumed blood. Assesses pericardium, epitorneal, splenorenal, retrovesicular spaces. Fast, portable, repeatable. Figure 17.6 shows fluid in hepatorenal space. After initial fluid and bleeding source identification, continuously assess for shock. Responders, normalizing physiology, proceed to comprehensive evaluation. Pitfall: high-rate IV fluids can mask ongoing loss, delaying intervention. Failure to respond to initial bolus indicates continued bleeding, needs immediate intervention. Intrathoracic, persistent bleeding after chest tube may need thoracotomy. Intra-abdominal. Unstable patients warrant emergent laparotomy. Pelvic fractures. Immediate minor sheet compression. Operative or angiographic treatment for persistent arterial hemorrhage.
Then we get to D for disability and E for exposure. How do these fit into the crucial primary survey for an elite professional after the ABCs are addressed?
These are crucial rapid checks right after circulation. For disability, quick determination of neurologic function. Assess TBI and SCI impact. Determine Glasgow Coma Scale, GCS, score for eye-opening verbal motor responses. Quantifies injury, predicts outcome. Note baseline before sedative spiralytics if possible. Spinal cord gross function assessed by extremity movement. Be careful attributing hypotension solely to SCI, neurogenic shock. Hemorrhage is frequent in trauma. Classic teaching: cervical high thoracic SCI needed. Upper extremity movement greatly diminishes likelihood. Look for hemorrhage first. For exposure and environmental control, ensures no injuries missed, maintains core temperature. Remove all clothing for complete head-to-toe exam, wound assessment, interventions. Measure core body temperature. Hypothermia is part of the terrible triad: coagulopathy, acidosis, hypothermia. Vicious cycle, worsening bleeding, reducing survival. Aggressive warming is critical. Warm blankets, bear hugger, elevated room temp, warmed 5E fluids, blood products. Preventing treating hypothermia is as vital as stopping bleeding.
Before we move to the secondary survey, let's talk about two high-stakes dramatic interventions sometimes done right in the ED, resuscitative thoracotomy and re-BOA. What are these heroic efforts and when are they truly indicated?
These are indeed last-ditch efforts for critically injured patients in or nearing cardiac arrest due to trauma, reserved for specific dire circumstances. A resuscitative thoracotomy, RT, involves opening the chest in the ED, performed for select cardiac arrest patients after critical injury, particularly penetrating chest trauma, first described by Cooley and DeBakey over 50 years ago. RT allows four crucial maneuvers: release cardiac tamponade, temporary cardiac injury repair, cross-clamping distal thoracic aorta, shunts blood to brain heart, manage intrathoracic bleeding directly. Given risk to providers and low salvage rates, patient selection is high stakes and must be precise. Best outcomes: penetrating thoracic injuries with any signs of life on ED arrival, reactive pupils, spontaneous ventilation, carotid pulse, measurable BP, movement, cardiac electrical activity. Seaman et al. 2015 review, 10,000 patients. Penetrating chest injury with signs of life, 21.3% survival without signs of life, 8.3% blunt trauma, much worse outcomes with signs of life, 4.6% survival without, sleep so 7%. NTDB review showed 100% mortality in blunt penetrating mechanisms for patients 57 years old.
Bilateral chest tubes, conservative transfusion more appropriate then. RT only done where immediate surgical backup for definitive repair is available if circulation returns. It's only temporary. Resuscitative endovascular balloon occlusion of the aorta, REBO, emerged over the past decade as a promising, less invasive method for temporary hemorrhage control in decompensating patients. Traditionally used in aortic aneurysm repair. First combat used for non-compressible truncal hemorrhage in Korean War. Now used in 51 U.S. trauma centers, median 6 year, for advanced shock, imminent arrest.
So inserting a balloon into the aorta from the leg.
Exactly. Introduced via common femoral artery, advanced proximal to injury zone, inflated, shunts blood to heart brain, decreases distal hemorrhage. Currently, no high-grade evidence fully supports all indications or proves superiority over standard care. Comparison to RT has survival indication biases. Risks: vascular injury, extremity ischemia, spinal cord ischemia, only deployed in systems capable of definitive surgical hemostasis and managing complications. Protocols vary, developed by multidisciplinary committees. It's still evolving.
So once those immediate life-threatening issues are identified and addressed in the primary survey, the ABCDEs, that's certainly not the end of the assessment, right? There's a need for a much more detailed, comprehensive look at the patient to find everything else.
Exactly. Once the patient is physiologically stable and not needing emergent intervention from the primary survey, the secondary survey is meticulously performed. ATLS defines this as a thorough head-to-toe examination and detailed patient history, often using the amply mnemonic: allergies, meds, past history, last meal events. Its purpose is to systematically identify all injuries, even subtle ones, and prompt further evaluation with imaging or diagnostics. During the secondary survey, key areas get detailed evaluation. Neurologic, more comprehensive than primary. Full GCS, detailed pupil area assessment, motor sensory function in all extremities, ideally before sedating paralyzing agents. Face and neck, identify abnormalities. Posterior neck surfaces, previously obscured by collar, can now be better examined if possible. Torso, check for pulmonary dysfunction, peritonitis signs. Subtle findings like seatbelt marks prompt further evaluation. Pelvis, assess tenderness and stability gently, avoid excessive compression. Rectal exam for prostate position, males, and gross blood. Extremities, identify open-closed deformities, swelling, assess distal perfusion carefully, color, temp, capillary refill, pulses.
Ankle brachial indices can help rule out major vascular injury. Check for compartment syndrome. Spine, carefully log roll to evaluate entire spine for deformity tenderness. Crucially, remove the long spine board ASAP to prevent pressure wounds. Penetrating trauma. Visualize all skin areas meticulously: folds, scalp, posterior neck, mouth, axilla, perineum, back. Mark wounds with radiopaque markers for imaging trajectory assessment. This systematic approach ensures nothing is overlooked.
This systematic approach makes sense, especially in critical situations. A lot of what we've talked about involves rapid decision-making, often in the face of massive bleeding. This leads us to a crucial concept called damage control. Here's where it gets really interesting, because it's a fundamental shift in how trauma is approached.
Damage control principles represent a true paradigm shift, moving dramatically away from immediate definitive repair of every injury in one long operation. It emerged from observing patients undergoing traditional lengthy repairs deteriorate intraoperatively, worsening the terrible triad of death: hypothermia, coagulopathy, metabolic acidosis. This lethal combination meant longer operations reduced survival regardless of surgical skill. So damage control halts this deterioration through a staged approach. Stage 1, in OR, expeditious hemostasis, rapid bleeding control, often temporary packing clamps, manage major GI contamination. quick repair section. Temporary abdominal closure, abdomen left open but protected. Then immediately to ICU for comprehensive physiological resuscitation. Definitive reconstruction is delayed until physiology normalizes, potentially days later. The term damage control was coined by Rotondo et al., 1993, for severe penetrating abdominal injuries. Their initial series showed similar overall survival, 55% to 58%, but a dramatic survival improvement in the subset. Major vascular injury plus O2, visceral injuries, 77% with traditional surgery.
Wow, 11% versus 77%. That's definitive.
Absolutely. It proved prioritizing physiology over anatomy in the sickest patients was superior. Damage control started for abdominal injuries, but is now universally applied to chest, pelvis, extremities when physiology deteriorates. Functioning in tandem is damage control resuscitation, DCR. Emerged from military experience, it's a comprehensive approach before and during initial surgery. DCR has 4 key components. 1. Permissive hypotension. Lower BP targets, for example, SBP 80-90, initially for patients without TBI, reducing bleeding pressure until surgical control. 2. Rapid hemostasis with early balanced transfusion. Crucial shift. Transfused blood products in 1.1.1 ratio, plasma.platelets.PRBCs, to mimic whole blood clotting. Solidified by the PRPPR trial, Holcomb et al., 2015, led to more hemostasis, decreased death from exsanguination at 24 hours. 3. Treatment of coagulopathy, actively address clotting issues from injury, shock, hypothermia, crystalloid. 4. Minimization of crystalloid, avoid large volumes, which worsen the terrible triad, to guide immediate massive transfusion protocol, MTP initiation. The assessment of blood consumption, ABC score, is a quick 4-point metric. Criteria.
Penetrating mechanism, positive fast, SVP 90 on arrival, pulse 120 on arrival. Scorio predicts MTP need, 75% sensitivity, 86% specificity. Critically, delay in MTP initiation associated with a 5% increase in mortality per minute. Many trauma centers have instant MTP activation protocols.
Every minute counts, literally.
Literally. In some centers, thrombolithography, TAGI, provides adjunctive real-time guidance to MTP, developed 70 years ago used in transplant cardiac surgery. TAG assesses clot formation dynamically from a whole blood sample. Figure 17.7 shows how deficiencies appear graphically. Prolonged R time, delayed clot start. TAGIs needs plasma. Decreased maximum amplitude, weak clot. TAG needs platelets, cryo. Elevated LY30, clot breakdown. TIAP needs TXA. Decreased R time, elevated MA, hypercoagulable. Potential benefits. Rapid results for individualized transfusion, blood product conservation, proven survival benefit, fewer hemorrhagic deaths in first 6 hours. Lastly, a crucial adjunct to MTP is tranexamic acid, TXA. A synthetic lysine derivative inhibits fibrinolysis, clot breakdown, by stabilizing existing clots. Previously shown to reduce transfusion needs in elective surgery. The landmark Courageous 2 trial, 2010, randomized 20,000 injured patients to early TXA, 8 hours versus placebo. Results. TXA group had decreased all-cause mortality, 14.5%, 16%, and reduced risk of death due to bleeding, 4.9%, 5.7%. Critically, no difference in vascular occlusive events. Despite limitations, many patients didn't need transfusion. It profoundly impacted care. TXA is now standard in many pre-hospital systems and trauma centers, strengthening DCR.
Now that we've covered the big picture systems and principles, the what and why, it's time to zoom in. You said earlier that for polytrauma patients, outcomes are often predominantly dictated by brain injury severity. Let's start there with traumatic brain injuries, TBIs.
Indeed. Let's deeply unpack traumatic brain injuries, TBIs. Even with optimal care, TBIs cause substantial long-term morbidity, account for 13 of trauma deaths, cost $75 billion annually in the U.S. Survivors often face permanent disabilities, from subtle cognitive deficits to needing lifelong care. It's profound. Long-term outcomes for polytrauma patients often hinge on the TBI severity, even if other injuries seem more immediately life-threatening. Epidemiology has evolved. Falls are now the most common cause, with extremes of age most vulnerable. Comprehensive guidelines exist, Brain Trauma Foundation, ACS East, WTA, though more high-quality evidence is always needed. At tissue level, TBIs result from direct energy transmission, blood accumulation, or both. Energy transmission causes direct injury at impact, coup, and opposite side contra coup as brain rebounds. Shearing forces tear vessels nerves leading to hematomas. Injured brain develops inflammation edema, worsened by ischemia, lack of blood flow. A critical concept is the Monroe-Kelly doctrine. The skull is a rigid, fixed-volume box. Contains brain parenchyma, CSF, intravascular blood, and equilibrium. Any increase in one, blood, edema, raises intracranial pressure, ICP, decreasing others. Uncontrolled volume increase leads to exponential ICP rise, compromising cerebral perfusion pressure, CPP, reducing oxygenation, increasing herniation risk. Let's look at specific TBI types. Figure 17.9. Lateral skull fracture, middle meningeal artery bleed, classic course. Initial loss of consciousness, then lucid interval, seems okay as hematoma expands, then profound deterioration. Favorable outcome if early decompression. Underlying brain often not severely injured. Subdural hematoma, SDH, tearing of bridging veins, deep dura, superficial to arachnoid. Hematoma is compressive, but outcome predicted by severity of underlying brain injury, contusion, axonal injury. Subarachnoid hemorrhage, SAH, diffuse bleeding from surface vessels into subarachnoid space. Not directly deleterious acutely, unlike aneurysm rupture, but indicates widespread injury needs surveillance. Parenchymal contusions, brain bruises from direct energy or contracoup impact. Diffuse axonal injury, DAI, widespread axonal disruption from severe rotational shearing forces. Imaging often underestimates severity. Punctate hemorrhage is loss of gray-white differentiation, clinically evident with poor neurologic status despite underwhelming imaging. Functional prognosis hard to predict early. For immediate management, primary goal is preventing secondary brain injury. Preserve recoverable brain cells, penumbra. Primary injury is irreversible. Outcomes dictated by preventing secondary injury, hypoxia, hypotension, increased ICP. Mainstay. Standardized ATLS-based resuscitation for normative brain physiology. Airway control and ventilatory support are critical. Transient hypoxia increases mortality fourfold. Unlike general damage control, hypotension in TBI is acutely detrimental, exacerbating ischemia. Maintain adequate cerebral perfusion. For hypotensive polytrauma plus severe TBI, military guidelines suggest 3% hypertonic saline bolus, 250 milliliter melons, then 50 to 100 milliliter LHR for resuscitation and ICP reduction, possibly improving survival. Anticoagulant reversal, warfarin, DOACs, is urgent due to risk of worsening intracranial bleed. Not the same paradigm for antiplatelets. Aspirin, clopidogrel, limited evidence for player transfusion DDD AVP benefit. Tranexamic acid, TXA.
Crash-free trial 2019 suggests mortality benefit in mild moderate TBI if given within 3 hours may become standard. Candidates for operative decompression transferred immediately to neurosurgical facilities. For evaluation, brief neurologic assessment and primary survey determines GCS score. Motor function is most predictive, localizing following commands. Pupillary size reactivity crucial. Oculomotor nerve impingement from ICP. Perform before sedation paralysis, if possible. After ABCs, patients with suspected TBI need immediate cranial imaging. Computed tomography, CT, without IV contrast is most important. Highly sensitive, rapidly available for acute hemorrhage, appears high-density white, shows mass effect, midline shift, also contusions, edema. Indications for primary decompressive craniectomy, space-occupying hemorrhage plus mass effect plus temporal decline in exam. Magnetic resonance imaging, MRI. No role in initial evaluation. Too slow, compatibility issues, but better anatomic detail later. In terms of TBI management beyond initial steps, most EDH-SDH with mass effect need immediate or decompression, craniectomy, moving skull piece, rare initially, 1.6%.
Depressed skull fractures may need early surgery for hemorrhage elevation. Post-op medical management. Ongoing neurologic surveillance, avoid intracranial hypertension. Severe TBI patients need close ICU monitoring. ICP monitoring often done directly, goal 22mm Hg, though best trip trial question universal need versus serial imaging gaps. Indication. GCS8 plus intracranial lesion on CT, external ventricular drains, EVDs can drain CSF, treat high pressures, no single device superior. Cerebral perfusion pressure, CPP, MEP, HEAP, ICP, goal 60-70mm Hg. MAP augmented with vasopressors, but ICP must still be acceptable. Neither ICP nor CPP target found definitively superior. Figure 17.1 shows a management algorithm. Persistent intracranial hypertension requires a tiered approach. Simple techniques, head-to-bed elevation, midline positioning, appropriately fitted collars, gravity drainage. Pier 1, adequate anesthesia and analgesia, short iconic saline, mannitol to reduce edema, neuromuscular paralysis, repeat CT, Tier 3, rescue salvage.
Decreased brain metabolism of barbiturates, mild hypothermia, neither clearly improves outcome. Mild hyperventilation, PCO2 30-35 for vasoconstriction, but only as temporary bridge, risk of ischemia. Corticosteroids, absolutely no role in TBI management, can worsen outcomes. ICP tends to peak 48-72 hours post-injury, then slowly decreases with edema reduction improvement.
From the head, let's move down the spine. Spinal injuries, while perhaps less immediately fatal than TBI, have incredibly profound and often irreversible long-term consequences, fundamentally altering a patient's life.
You're right. Spinal cord injuries, SEIs, are fortunately not common causes of early mortality except high cervical injuries impacting breathing. But they result in severe, irreversible long-term disability and lost productivity, especially for young patients. Blunt vertebral column fractures alone are 10x more frequent than SEIs, with 8% mortality, often due to associated injuries. Both blunt and penetrating mechanisms cause SCI, blunt trauma, direct impingement by bone, or secondary compression from hematomedema. Cervical spine. Highest incidence, 55% due to mobility, mechanisms, axial loading, Jefferson C1 burst,
flexion extension, hangman C2, rotation, lateral force adductoid, distraction, C5, C6, most susceptible, thoracic and lumbar spines, limited mobility, mechanisms, high association with retroperitoneal visceral injury. Hands fractures common in MDAs, high association with retroperitoneal visceral injury, penetrating mechanisms, direct laceration or indirect injury via ischemia vertebral fracture. Theaura, SCI without radiographic abnormality. Neurologic deficit unexplained by imaging. Challenging.
For immediate management, spinal immobilization, rigid collar longboard, is priority pre-hospital and on arrival. Assume spine injury and all blunt trauma until excluded. High cervical SCI, C3-TC5, can cause immediate respiratory suppression, phrenic nerve paresis, needing urgent airway ventilation. Injury to descending sympathetic pathways, OT6, can cause neurogenic shock. Hypotension plus warm extremities plus maybe bradycardia, means atropinotrophs. Due to loss of vasomotor tone, unopposed vagal outflow, distinguished from spinal shock, temporary loss of reflexes muscle tone after SCI, transient physiological state. For evaluation, gross assessment of extremity movement and primary survey. Detailed neurologic exam is secondary. Characterize deficits by dermatome sensory, myotome motor. MyTLS app helps. Classifies as CI, complete, no function below, or incomplete, some retained. A CISA impairment scale, A, complete, B, sensory incomplete, CD, motor incomplete, E, normal. Standardizes assessment. Tenderness, deformity over vertebrae indicates acute fracture. Reassess frequently for new deficits. Spine surgeon consultation guides evaluation, expedites OR, pre-hospital screening tools.
Canadian C-spine rule or NXSQS criteria can clear C-spine clinically in select patients. No tenderness, normal consciousness, no distracting injury, no neurodeficit, no intoxication. AST trial 2019 showed 99% negative predictive value, even with distracting injury, including patient 65. For imaging, CT is a modality of choice. High quality, sensitive, rapid, largely replace plain X-rays. Dedicated cervical spine CT, often sufficient to remove collar if negative, even if intoxicated. Sagittal coronal reconstructions improve visualization. CT limitations. Excellent for bone, poor soft tissue detail for SCI. Spinal canal compromised edema on CT suggests cord injury. MRI often needed to characterize soft tissue, neck pain, normal X-ray, especially within 72 hours. Valuable for guiding early surgery. Prognosis. Figure 17.12 shows severe cervical fracture with subluxation, spinal canal compromise. Consider patient stability for imaging timing. For management, strict immobilization until injury is ruled out and stabilized. Exception. Penetrating spine trauma, pre-hospital immobilization shows no benefit, associated with increased mortality. Raising head of bed may help airway. Remove long spine board early to avoid pressure wounds.
Prompt spine surgeon consultation upon SEI recognition. Transfer if needed. Avoid delays from unnecessary imaging.
So getting the right specialist involved quickly is key.
Absolutely. Neurogenic shock needs aggressive resuscitation. Volume expansion, vasopressor centrotrobes. No single agent superior. Brief hypotension. Detrimental. Treat aggressively. Challenging with combined hemorrhagic neurogenic shock. MAP augmentation post-shock debated. Guidelines suggest MAP 85-90 for 7 days. Associative data. Future studies needed. Corticosteroid therapy. Controversial. Nasky's trials showed some motor improvement with high-dose methylprednisolone within 8 hours, 24 versus 48 duration. Similar functional recovery, but 48 had higher severe sepsis pneumonia rates. No mortality difference. Short duration steroids remain a potential option, considered in close consultation. Trauma neurosurgical, weighing benefits versus risks. Surgical management varies. Injury pattern, stability. Decompression within 24 hours improves functional outcomes. Cervical fracture dislocation. Traction and ED for alignment. Unstable injuries. Operative fixation ASAP after stabilization. Stable injuries. Immobilization. Collar brace. Follow-up x-rays. Table 17.5 details common fractures. Jefferson odontoid hangman compression burst chance and management. Collar halo surgery TLSO. Early physical therapy rehabilitation is the next best influence on functional outcomes. No regenerative options currently, but stem cells show promise in research.
From head and spine, let's look at the face. Injuries here can be very visible, obviously with major cosmetic implications. But for trauma professionals, what are the actual life-threatening concerns beyond just appearance?
You're touching on a common misconception. Maxillofacial injuries are common in blood-penetrating trauma, and while disfiguring, they're rarely immediately life-threatening alone. However, the foremost concern is tissue damage, compromising the airway or obstructing intubation access. Edema can worsen rapidly. Also, bleeding from the rich facial vasculature can be significant, contributing to urgent airway needs if blood obstructs. Facial bone fractures, e.g. GLO fortnite case disruptions, are common. Morbidity can result from sensory disruption, eyes, ears, nose, mouth, but poor functional outcomes are often due to concomitant TBI, not the facial injuries themselves. For immediate management, prompt airway assessment management paramount, especially with lower face involvement or significant bleeding swelling. Early intubation can be life-saving if airway stability is a concern. Blood debris complicates intubation that anticipates a backup surgical airway. Bleeding is immediate concern due to vascularity. Direct pressure, suture ligature resuscitation. Rapid wound closure may be needed. Deep vessel fractured bone bleeding may need angioembolization, often exacerbated by hypothermia coagulopathy. Prevent, treat aggressively. For evaluation, physical exam determines soft tissue extent. Eyes, check for diplopia. Visual acuity changes. Globorbid evaluation for rupture. Extraocular muscle entrapment needs urgent treatment. Ears, external exam, canal drainage, possible skull base fracture. Midface mandible. Stability occlusion, dentition, deformities. Forehead midface indicate frontal maxillary fractures. Facial nerve function. Assess with fracture soft tissue injuries. Imaging often needs three-dimensional imaging with thin-cut CT scans for complex facial bones. Sagittal coronal 3D reconstructions aid assessment. Indicated for severe external injury, facial abnormality on cranial CT, or concern for fracture. Timing. Only after immediate life threats addressed. Facial trauma management, usually not time sensitive. In terms of management, maxillofacial surgical consultation often beneficial. Bleeding control. Direct pressure. Wound closure. Angiography embolization for severe cases. Wound care. Debride non-viable edges. Irrigate. Simple lacerations close with local anesthesia. Deep absorbable fine skin sutures. Complex areas. Lip, nose, ear, orbit need special consideration.
Definitive facial fracture management rarely required acutely can be deferred. Exceptions. Severely depressed fractures involving brain or muscle entrapment need urgent reduction. Most repaired after edema subsides, 5-10 days. Large open wounds, fractures involving sinus aerodigestive tract may need short course antibiotics. Avoid overextension. Repair often open reduction internal fixation, screws plates. Aim for optimal functional cosmetic outcomes. Preserve eye motor function, orbital fractures, mandibular fractures. Fixation, wired jaw, or internal plating for displacement.
Let's transition to the neck. Another area with an incredibly high concentration of critical structures, blood vessels, airway, esophagus, nerves, making it potentially devastating when injured, but also challenging for diagnosis. What are the key considerations?
You precisely highlighted the challenge. The neck is anatomically dense, complicating diagnosis and treatment. An organized approach is crucial. Neck trauma is relatively uncommon, but has highest mortality, 17% for AIS UA3 NTDB, underscoring the danger. Penetrating injuries, gunshot stab, most common. Directly lacerate vascular aerodigestive structures, causing substantial bleeding or contamination. Blunt mechanisms uncommon, sudden compression, larynx, trachea fracture. Pharyngeal-esophageal injuries, rarer but high risk for delayed complications. Leak, abscess, mediastinitis. Blunt cerebrovascular injuries, BCVIs. Blood force to carotid vertebral arteries, seatbelt, whiplash, range from intimal tears, grade 1, to transection, grade V. Morbidity mainly from thromboembolic stroke. For immediate management, rapid intervention, crucial. Airway is highest priority. Deterioration can be rapid. Causes. Direct larynx trachea injury, challenging. Expanding neck hematomas, compress airway. Intervention. Immediate intubation for expanding hematoma or impending compromise. For patients maintaining airway, a planned approach, intubation awake tracheostomy in OR is vital. Avoid rushed intubation without backup.
Loss of airway. Emergent cricothyroid episiotomy tracheotomy. Upper airway injury may need tracheotomy. Hemorrhage is other major concern. Carotid sheath vasculature often needs surgical control. MTP-based resuscitation. Direct pressure, finger Foley balloon, manages most bleeding during transport to OR. Patients needing surgery for neck bleeding or significant aerodigestive injury. Best served by airway management in OR just before hemorrhage treatment. For evaluation, unstable patients or those with hard signs go immediately to OR for exploration. Hard signs: airway compromise, massive subcutaneous emphysema, air bubbles from wound, expanding pulsal hematoma, active bleeding, new neurodeficit, hemonesis. Stable patients undergo thin slice multi-detector CT angiography, MDCTA. Penetrating injuries classically zoned by surgical accessibility. Zone 1, thoracic inlet to cricoid. Large vessels, trachea, esophagus. Complex mixed into chest. Zone 2, cricoid to angle of mandible, most accessible. Carotid vertebral arteries, jugular, aerodigestive tract. Zone 3, angle of mandible to skull base. Difficult exposure, no zone approach. Traditionally, Zone 2 with platysma violation mandated exploration.
Now, only hard signs require immediate OR. Others, stable, get radiographic assessment first. MDCTA significantly decreased negative neck explorations. Inalba et al. 2012 showed 100% sensitivity, 97.5% specificity for penetrating vascular aerodigestive injuries. Bob's evaluation of neck as unit often obviates other invasive tests, bronchoscopy, endoscopy, esophagram, DSA. Only equivocal MDCTA, retained fragments, need selective diagnostics. Blunt trauma and BCVI. MDCTA revolutionized detection. Previously thought uncommon, high-risk screening criteria plus better detection increased diagnosis. Denver criteria, box 17.4, used to screen. Hematoma, hemorrhage, neurodeficit, group 50, stroke on CT, cervical fracture, seat bump mark, etc. Now, MDCTA is study of choice for BCVI. Incidence 2-3% blunt trauma. Liberal screening prompts MDCTA for injury above clavicle, unexplained neuroexam, Horner syndrome. Hard signs, immediate neck exploration, WTA 2013 guidelines. Surgical approach, often incision along anterior sternocleidomastoid. Collar incision versatile.
Divide platysma, dissect SCM to expose carotid sheath, carotid vagus, IJV, venous injury, IJV repair or ligation, ligate facial vein for deep exposure, arterial injury, retract IJV laterally, expose carotid vagus, and control carotid proximally distally. Avoid vagus hypoglossal nerve injury, carotid repair, simple closure anastomosis for short segment. Graft synthetic vein for extensive loss. Damage control. Shun ligation in extremis, high stroke risk. Tracheoesophagus exploration, retract carotid laterally, dissect medially. Identify esophagus anterior to vertebrae, and G-tube helps. Soft deal injuries, debride, close 1 to 2 layers, mucosal muscular. Wide drainage crucial, commary closure, absorbable suture if small tension free, large defects. Presage injuries, tracheostomy through injury. BCVI treatment considered for pseudoaneurysm dissection. 70% nasally wetter, 10% user over magnetic or escalation energy. Resection is cut limitation. 9 is a circular sacral liver injury. In G vascular stenting, considered for pseudoaneurysm dissection, 10% use. Potential ischemic risks.
Initiate therapy ASAP safely. Consider bleeding risk from other injuries. Majority of strokes early, but delayed therapy still beneficial. Anticoagulation, heparin PTT 40/50s or daily 325 milligram aspirin equivalent. Follow-up imaging. Repeat MDCTA 24/48 if indeterminate. Confirmed injuries. Repeat 7-10 days for progression resolution guide therapy duration. Persistent injury. 3 months treatment. Outpatient follow-up MDCTA.
From the neck to the chest. These are incredibly common and potentially immediately life-threatening injuries, directly impacting the vital cardiopulmonary system. What makes them so dangerous, and what are the key interventions?
Indeed, thoracic injuries are exceedingly common. 22% trauma patients, 9.5% mortality in TBP, life-threatening due to vital cardiopulmonary structures. Blunt injuries, falls, MVAs, energy transmission, compression deceleration, cause significant lung contusion, local diffuse, penetrating. GSW stabs, direct laceration of pulmonary mediastinal structures. Despite severity, 10% blunt, 15-30% penetrating chest trauma requires surgery. Most manage simpler means, immediate management, airway ventilation immediate for pulmonary compromise. Tension pneumothorax, decreased breath sounds, poor compliance, shock, urgent decompression, needle or tube thoracostomy, external bleeding, direct pressure, resuscitation, hemodynamic instability, usually hemorrhage, also cardiac dysfunction, tamponade contusion, air embolism. Pericardial fluid, ultrasound or window, especially after penetrating trauma. Persistent shock blood loss often needs operative intervention. Cardiac arrest, penetrating, almost universal. Evaluates large pneumohemothorax, need immediate tube.
May suggest blunt aortic injury, widened mediastinum, etc., but lacks detail for screening. Thoracic MDCTA, standard for stable patients. Superior visualization, chest wall, vasculature, pleura, parenchyma. Unreliable for pericardium motion, sufficient to guide operation without standard angiography. Penetrating specifics, rapid ID, mark wounds. Cardiac box injuries, high risk if mediastinum involved or crossed. Ultrasound. Immediate pericardium assessment can be false negative if decompresses into hemothorax, great vessels. MDCTA may be impeded by fragments, needs standard angiography. Trachea airways, Wethiophysta promotabia suscepti, optoclasp combination, esophagoscopy plus contrast esophagography, 100% sensitivity combined. Management. Soup thoracostomy at above nipple, mid-axillary line, triangle of safety. Placement. Incision and triangle at above nipple, 5th to 6th intercostal space to avoid abdomen diaphragm. Tunnel superiorly, blunt entry, palpate lung. Sizing. Typically 32-36 cm, but evidence suggests smaller diameters equivalent. Confirmation. Free spinning tube.
Connect to underwater drainage, 20 centimeter H2O section. Indications for thoracotomy. Operative. Traditional indications, Vietnam date, 1500 milliliter initial output, 150 to 200 milliliter SR for 2-4-Hers. Persistent instability transfusion, not based on contemporary trials. Crucial questions, stay bleeding ongoing or accumulated as a surgical, impacting physiology, e.g. 1500 milliliter initial, little ongoing stable, patient wall may not need thoracotomy. Patient physiology response guides planning.
So it's not just about the number, but the context.
It's exactly. Other indications, massive air leak plus persistent pneumothorax, drainage of esophageal gastric contents, surgical approaches, posterolateral thoracotomy, lungs, pulmonary vessels, diaphragm,
our-side esophagus trachea, left thoracotomy, distal esophagus, L lung, L ventricle, descending aorta, L subclavian, median sternotomy, versatile, R heart, ascending aorta, pulmonary vessels. Chest wall and pleural space injuries. Most common thoracic injury. Rib fracture, 65% blunt, 25% penetrating. Mortality, 7% blunt, 19% penetrating due to associated injury. Mechanisms, compression, steering wheel seatbelt, flail segment. O2 adjacent ribs fractured to O2 locations. Paradoxical movement. Pulmonary contusion is greatest insult. Pneumothorax common. Evaluation. Exam. The dinner exam. X-ray. Pneumohemo visible on X-ray considered for chest tube. Occult pneumothorax on CT, not X-ray. Observation safe if small. CT radial diameter 35 millimeters. Stable, no compromise. Buzine ed. 2019. Re-X-ray 12-24 hour. Hemothorax visible on upright X-ray 400-500 middle low. Evacuated tube. Retained hemothorax considered VAES drainage. Reduces duration, stay, cost, prevents later surgery. 33% NPM risk. VATS best 3 to 7 days post-hospitalization. Chest tube removal. Safe after evacuation, unsealed, 300 milliliter output 24 hours. Rib fractures. Impact varies. Pain inhibits pulmonary toilet, respiratory compromise, pain management, multimodal narcotic sparing, pain service, epidural. Adequate analgesia crucial. Surgical stabilization, a renewed interest. Trials show decreased pain, improved QOL, 2 WKs, non-segmental. Sternal fractures, often non-operative. Some benefit from reconstruction, operative planning, case-by-case, risk-benefit discussion, ongoing questions about role, pulmonary injuries, common 13 NTDB chest trauma, mortality from respiratory failure, ARDS pneumonia, pathophysiology, energy transfer, no tissue damage, hemorrhage, Mohs shunt, hypoxemia, inflammatory response, multi-organ dysfunction, often with flail segment, more clinically important. Penetrating, say GSW is most common, direct laceration plus surrounding contusion. Evaluation, clinical suspicion. X-ray may suggest, typically visible, 24-48 hours later, early appearance. CT valuable.
Hard to differentiate from atelectasis. Rule. Atelectasis doesn't cross fissures. Contusions are segmental. Injured tissue near chest wall trauma. Highly suggestive. Higher density on CT. Management. Supportive care. Pulmonary toilet, pain control, monitor for hypoxemia or work of breathing, agitation. Progression. Most resolve. Some need mechanical ventilation, ECMO. Large review. 70% survival from cannulation, 60% discharge for trauma, ECMO, ARDS common. Operative measures. Non-op thoracostomy managed majority. Operate based on ongoing bleeding impacting physiology. Persistent drainage, initial output. Tube thoracostomy manages low pressure, lung bleeding, small air leaks. Ongoing bloody effluent suggests central, high pressure source intervention. Endovascular. Embolization of pulmonary vessels, alternative with IR support. Surgical challenges. Blunt causes diffuse injury, harder to treat surgically, worse outcomes. Penetrating. Tractotomy, wedge resection common, 20 to 40%. Blunt, lobectomy, pneumonectomy, more common if resection needed, 15 to 20%. Healer control, clamp or twist for major bleeding. Parenchymal bleeding, suture ligation. Stapled tractotomy exposes vessels bronchi. Thrombopneumonectomy, extremely morbid, 50% mortality. Only for extremists after other attempts fail. Damage control in chest. Packing, temporary closure for tubes. Packs minimal space, allow lung expansion. Cardiac injuries, uncommon, severe. Penetrating heart injury, 1-2% penetrating trauma, 10% penetrating chest, NTDB, likely underestimates 94% immediate lethality.
Well,
Hospital arrival mortality, 17-58%. Location often suggested by cardiac box injury. Presentation. Extremists with tamponade or bleeding into pleura, identified during ED thoracotomy. Tamponade indicators. Beck triad, hypotension, JVD, muffled sounds. Inconsistent. Ultrasound valuable for pericardial fluid, can be false negative if decompresses. Subsymphoid window required if ultrasound inconclusive, false negative. Direct visualization, extended sternotomy if blood seen, recent evidence. Pericardial drain if stable self-limiting, cardiac collapse operative. ED thoracotomy, left anterolateral clamshell. Median sternotomy, best if time permits. Surgical repair, atrial, Satinsky clamp, running permanent suture. Ventricular, challenging, bleeds significantly. Manual hold or horizontal mattress sutures, avoid coronaries, pledgets. Temporary control, transport.
Staples, Foley catheter through wound, inflated. Tension carefully. Blunt injury, less common, 2.2% blunt chest, mostly contusions, arrhythmia, supplemented, rare. Heart failure, cardiogenic shock, diagnosis controversial, ECG plus troponin I, if both negative, rules out. New ECG abnormality, evident for monitoring, hemodynamic instability, heart failure, prompt echo, wall motion, valves. Management, cardiogenic shock, inotropes, RV afterload reduction, structural abnormalities, adults, urgent operative repair, thoracic aortic injuries, uncommon, poor outcomes, 80%, blunt traumatic aortic injury, ETAI, die pre-pivotal, 50% hospital survivors die within 24 hours.
Incidence, underestimates. Mechanisms, PTAI. Rapid deceleration, hair is wall and hair ligamentum arteriosum. Low common 3% penetrated chest, 90% mortality. Evaluation, X-ray may suggest wide mediastinum spectra, but high miss rate. Geography, standing injury. Wide mediastinum, etc. But high miss rate. Helical CT angiography standard for high energy mechanisms. CT angiography. PTA, the care 17, the channel. Fixing not that. The end of death. PTAI. PTAI is curious, and the kids like you need to see me. Yet, I think I can share. I'm not actually like this. Just I can't get my I can't see the ends pretend that he's different black. That's not that. If I went to that, estimate that the standard patient staffing to go to the task. That's a just because you can damage just instead of side factor. Because others can take that. Jail life is there. It doesn't get to get I know can't stand there's a story to and the expression is not your never express has been session from that story. Just it was comes to the day for kind of the dish to the fish. I just you know the nation is game. I see it's on the situation. I'm sorry. I how to
Intimal disruption. 2. Intramural hematoma. 3. Pseudoaneurysm. 4. Rupture. Fig 17.1 Neen shows contains pseudoaneurysm. Sufficiency. Chest CT usually sufficient for planning. Standard angiography rare. Penetrating, identified on CT or at exploration, often in extremis. Management. Operative repair. BTAI grade 3+, required due to rupture risk. Progression usually slow, allows addressing other issues first. Aortic wall, stress control essential until repair. Beta blockers. Labetalol, esmolol. Treatment of choice. Thoracic endovascular aortic repair, TEVAR. Equivalent mortality and morbidity to open, fewer complications. Minimally invasive, rapid catheter tech, access via groin, stent graft placed fluoroscopically. Complication may cover left subclavian, carotid subclavian bypass symptoms, open surgical repair, left thoracotomy, replace segment with graft. Assistance, cardiopulmonary bypass, femoral left heart. Non-operative management, small animal tear, grade 1. Many heal. Beta blocker therapy, follow-up imaging for resolution, tracheobronchial injuries, uncommon, significant morbidity, mortality, penetrating most common, 1% historically. Blunt, also uncommon. Large energy transfer, avulsion from carina, rupture from compression against closed glottis. Mechanisms, GSW's direct laceration. Presentation dictated by location. Thoracic, tracheoproximal bronchi, large pneumomediastinum. Distal airway, reduced pneumothorax. Key sign. Continuous air leak plus persistent pneumothorax highly suggestive. Physical exam. Significant subcutaneous air. Diagnosis. Bronchoscopy. Rigid or flexible. Identifies, characterizes injury. Management. Careful airway control. Avoid disruption. Bronchoscopic guidance. Non-operative. Injuries. 13 circumference if lung expand, leak resolves. Humidified O2. Suction. Observation. Operative. Right posterolateral thoracotomy. Tracheal airways proximal main stem. Left thoracotomy, distal L, mobilize intercostal muscle flap for coverage. Repair. Histonoplast, abnormal suture, large injury, resection anastomosis. Protect repair, advanced ETT distal, dual lung ventilation, ECMO. Mortality substantial, 35%. Due to mediastinal sepsis, adjacent injury. High mortality due to diagnostic treatment delays. Mechanisms. Penetrating. Direct laceration. Blunt. Rare rapid interluminal pressure increase. Blowout, usually distal. Evaluation. Clinical suspicion penetrating near mediastinum. Diagnostic modalities, combination best. Contrast esophagography, water-soluble than barium. Combined sensitivity, 100%. Helical CT esophagography alternative. Chest CT, no contrast. May show adjacent air inflammation. Location key for planning. Management. Immediate identification, repair, distal contamination. Closure, ideally 2 layers. Mucocell muscular. Adequate drainage. Cervical approach discussed earlier. Thoracic, upper mid-diastasis larycotomy. Lower natural thoracotomy. Vascularized intercostal flap for coverage. GE junction injury, nasal apparat. Closure 1 to 2 layers. Cover, muscle flap. Fundicularity. Wide drainage critical. Decompressed stomach, distal feeding access. Post-repair esophagram day 5. Salvage, late inflamed. T-tube diversion stenting esophagectomy, rare. Diaphragmatic injuries. Overall, 0.46% NTDB 2012. Penetrating more common, 67% versus blunt, 33%. Mortality higher blunt, 19.8% versus penetrating 8.8% due to its associated injuries. Left side, 75%. Liver protects right. Morbidity. Delayed ID progressive herniation. Diagnostic challenge. High suspicion needed. X-ray. Heinz Stilleke Manigi Sees Day. X-ray exhibition stillage errate. Ecri mestro camlegi metrophos respirdiaphragm abnormality ernge. X-ray. Visis percios ecologies irritandal jane. Kitsra secatalange 17.96 stilicare. Ecalistus in secre ernge, who has founded a Munalayan 20A. A Robin Eberlock of Amnomar may consider the low-wing trajectory. Extratritzis ecality. Della Rost, ex CT azulgus, all absorbing sections ecologies may consider an pay. Cancer evaluation cicatorial plasers up once. Little 2 segel layer mixtures are collected of ATs. Ancriocephalomations are mylian ham du anerotorus de green. Achua. Ryer. Intersignigan secretary signigri man and abdominal and labor. Four additional laters who a diaphorcivic panel. Beveroxetanly. Infrenity prohorticid petonulation, pruders to vital organs, morbid denervopathy from bleeding, visceral perforation, marcliata. Mechanisms. Vexogen salivation amid the singular sextant clean liver, contusion laceration, hollow visceral rupture, penetration important, direct laceration, aboblubin bleeding contamination, initial evaluation priority. Rapidly determine presence, absence, ongoing hemorrhage. Responders have bled. Non-responders need immediate intervention. Transient responders, initial improvement, then instability. ATLS primary survey designed for rapid ID cavitary hemorrhage. Blunt abdominal trauma evaluation, figure 17.21. Ultrasound, nearly ubiquitous. Adjunct primary survey. Rapid bedside. Evaluates pericardium, hepatorenal, splenorenal, retrovacuolar space. Repeatable, indication for exploration. Non-responders plus fast fluid. DPL alternative if fast unavailable, 10 milliliter blood, GI contents, somewhat limitations. Fast operator habitus gas, DPL rarely done, iatrogenic risk, obesity contraindication, low specificity. Both can evaluate retroperitoneum. CT primary method comprehensive workup. Supports NOM solid organs. Technique. 40 contrast portal venous phase. Best solid organ perfusion. Visualizes injury severity, active bleeding. Guides operative non-op angiographic therapy. Historical shift. Initially all hemoperitoneum explored. Physiology more indicative. Volume accepted stable patients. Contemporary rapid CT DCR continues. Some advocate whole body CT hypotension SBP90. Limitation CT. Less capable detecting hollow viscera, though improving. Clues. Wall thickening. Irregular enhancement. Mesenteric defects. Unexplained free fluid. High risk. Oral contrast has little value. Isolated pneumo unreliable. Serial exams crucial for observed patients. Laparoscopy, safe alternative exploration, stable patients. Penetrating abdominal trauma evaluation, unique approach. Assess ABCs, identify all wounds, GSW's X-ray, mark wounds, trajectory, pneumo. Fast utility controversial. Missile count check, extremis, Dale CTT. Further delineation, thoracoabdomen GSW's, head, evaluate chest, stab wounds, immediate laparotomy for instability, peritonitis, evisceration, unexaminable. Evaluate peritoneal violation, local exploration, US, CT, laparoscopy. Flank back, contrasted CT, plus maroscopy contrast, active extravasation or consider angioembolization, anterior abdominal, attending discretion, local exploration, ethereal exams, imaging, laparoscopy. Laparoscopy, accurate for violation, controversial for ideal injury, user dependent. Indicators for exploration, peritonitis, instability, HB drop, leukocytosis, discharge, stable 24R9 diet tolerating, needs close surveillance infrastructure.
Thoracoabdominal stab, CXR, pericardial US, LUQ stab, likely, laparoscopy, diaphragmatic assessment, RUQ optional, new to liver, management, general abdomen. Laparotomy, explore repair, systematic exploration crucial, damage control, abbreviate if deteriorating, exposure, bedline incision, initial. Evacuate blood, pack 4 quadrants, temporary hemostasis, fix retractor, remove replace packs, GI tract evaluation, GE junction to rectum, enter lesser sac, repair identified injuries, physiologic compromise, wrap abbreviate, damage control, temporary closure. Fascia closure is stable, subcutaneous wound based on contamination. Splenic injuries, first, second most common abdominal organ, isolated, 42%, blunt, compression fracture, deceleration, tear capsule parenchyma, subcapsular hematoma, figure 17.73, penetrating less common, 8.5%. Hemorrhages ongoing or resolved, operative indication on responders plus fast fluid. NO, common responders, risk delayed rebleed, mostly 72 hours. Rates increased 40%, a 90-70% mortality decrease higher grades. Evaluation or idea unstable patients, 10% blunt. CT with IV contrasts most valuable stable patients, 96 to 100% sense spec. Parenchymal disruption, hematoma, free blood, active bleeding.
Contrast, extravasation, literature accumulation. Free or pseudoaneurysm. Other types: subcapsular hematoma, devascularization. AAC, spleen injury scale, table 17.6, grades by AV, parenchyma subcapsular vascular. Management: angioedema success, 90% high volume centers. Advantages: reduced costs, complications, transfusions, non-therapeutic laparotomies, mortality. Angiography and embolization. NOM failure rates 5%. Grades 3A with increased use. Protocol: stable plus extravasation, pseudoaneurysm, CA, IR, evil embolization. High grade also evaluated within 24 hours. No specific factors consistently. ID patients needing prophylactic operation if stable. Delayed intervention. No increased complications. Mortality. Mobilized spleen. Figure 17.29. Divide lateral peritoneum. White line told. Blunt plane posterior splenectomy. Ligate short gastrics. Hilly vessels. Avoid pancreas stomach. Granulate of pancreas tail injured. Post-splenectomy vaccines crucial. Encapsulated bacteria prevent top PSI. Salvage techniques limited utility given effective pneumoendohepatic injuries extremely common. 22.2% blunt. NTDB 2012.
Most common penetrating 26.1%. Blunt compression, shearing forces, tear tissue disrupt attachments. Penetrating, direct laceration, contusion. Mortality decreased with shift. Endoendoscopic. Morbidity, bleeding, biliary hemobilia fistula, infection, necrosis. Evaluation. Initial diagnosis, often laparotomy, unstable patient, fast fluid, CT5E contrast, stable patients, excellent detail, accurate characterization, timing, 3 phases, non-con, arterial, portal venous, findings, parenchymal disruption, perihepatic blood, hemoperitoneum, contrast, extravasation, blush accumulation, ACE liver injury scale, taints 1 aid, NOM approach of choice stable patients regardless grade. Most HETIM NOM success, Heon-Kime, FLIAM, and Z still need surgery. Polanco ROI, report 9% mortality complex resection, post-embolization, ICU surveillance. Improves NOM success, complication success, NOM 12, 14%, biloma, hemobilia abscess. Diagnosis, CTOCS. Treatment, percutaneous drainage. ERZP stent bile leak. Laparoscopiloperotomy. Biliary sites. Hemobilia angioembolization. Operative Cs in stable patients. Failure rates 9.5% blunt, 5% GSWs, midline laparotomy. Perihepatic packing, temporary control, mobilize lobes, divide triangular ligaments, caution, preserve. Tamponade, retrohepatic. Pringle maneuver, valuable, severe bleeding, occludes inflow. Explore laceration, suture ligate. Devitalize parenchyma. Devitalize parenchyma. Impleginate. Debride loin. Devitalized parenchyma. Gabdizolite. Debride devitalized parenchyma. Drains by a leak risk. Momentum pedicle into injury. Percariopatic VC injury. Deridolization. A ping pack. Do not explore unless actively bleeding. Damage control. Often needed. Surgical bleeding must be controlled. Packing blunt 28.2% due to high energy associated injuries. Penetrating low mortality 2.2%. Blinded. Pressure increase meteorally. Penetrating. Full thickness perforations. Pillage. Exam peritonitis. After onset. Wood location suggestive.
CT limited sensitivity, specificity, hollow viscous. Secondary signs. Wall thickening. Enhancement. Mesenteric defects. Free fluid without solid organ trauma. Unreliable loan. Isolated pneumo unreliable. Observation period possible. Expeditious decision if suspicion high. Mortality increases with delay. Management, exploration, full evil, anterior, posterior, lesser sac, hematomas, evacuate, marginal perforation, control bleed, closed seromuscular layer, full thickness perforations, debride, closed 1 to 2 layers, absorbable, pleasant burning, non-absorbable. Stapler, okay. Challenging locations may need better exposure, destructive injuries, rare. Barrel carcinal gastrectomy, reconstruction, duodenal injuries, uncommon, tuberculotic injury, blunt helps it. Epigastric blow, narrow object contusion rupture, morbidity, mostly septic complications, repair failure, blunt. Diagnosed laparotomy, blunt, challenging, high suspicion. Exam findings subtle, retroperitoneal, CT most valuable, low threshold exploration findings, thickened wall, periduodenal air fluid, low grade hematoma ID.
Repeat imaging, stable, suggestive patients. Oral contrast, CT Jugi. Perforation on imaging, immediate OR. Maintain low threshold, explore false negatives. Management, depends location, destruction. Hematomas, often resolve non-op. Concern only if obstructs. Obstructing. NG-decom TPN, Reval 5, 7 pence. Persistent 14B Gator, evacuate evil perforation, stricture pancreas. Incidental hematomas, laparotomy. Don't open unless concern full thickness. Primary repair, 98% amenable. Single double layer after debridement. Kosher maneuver for exposure tension-free repair. Tissue loss transection. Resection, primary anastomosis, if ampulla not involved, short segment. Longer near ampulla, Rouzon wide bypass. Reinforced with omentum. Additional maneuvers controversial, diverticulization, pyloric exclusion, tube duodenostomy, individualized, drain placement not mandatory, may create controlled fistula if leak, damage control, resection plus drainage plus discontinuity, effective contamination control, pancreatic injuries, common association duodenal, low incidence point associated pathology, penetrating more common 4.4%, mortality, morbidity, difficult isolate associated pathology, increases AAST grade up to 40% V, delay diagnosis management.
Ductal injury leak. Ductal injury leak was significant. Caustic enzymes. Mechanisms. Direct laceration, blunt crushing of spine. Evaluation. Challenging. Retroperitoneal limits exam. CTIV contrast best view 1542.27. Findings. Malperfusion, fluid hematoma, stranding. Limitations. Sensitivity, specificity, inconsistent. Parenchyma 47-79%. Duct 52 to 54%. CT alone may not rule out. High suspicion. Missed trauma 15%. Repeat CT may show evolving inflammation. Serum amylase 3 hours post-injury, sensitive but not specific. Ductal imaging. ERCPM, RCP, increased yield, valuable therapy planning. Management. Significant injuries need surgery. Exposure, entire pancreas. Mobilize hepatic flexor, divide gastrocolic, crucial percent. Ligand issue, limited destruction. Drainage alone, controlled fistula, often closes. Biliary depression, ERCP stent, helps. Massive destruction of combined pancreatic duodenal hoopal. Major surgery, high complications. Only stable patients. Others abbreviated OP, later reconstruction.
Damage control. Hemorrhage control. External drainage. Temporary closure. Re-explore. External drainage. Prevents retroperitoneal enzyme exposure. Less severe. 3. No duct. Drainage. Closed suction best. Distal feeding access. Early enteral nutrition. Small bowel injuries. Frequent penetrating. Rare blunt. Mortality 15 and 20%. Vascular. Pathophysiology. Crush rupture. Shear. Penetrating. Cytotini perforations to destructive. Blunt. Padarovely. Prush. Deceleration. Shear. Mesentery injury. Edema under suspicion. Evaluation. Penetrating. Often ID'd exploration. Presentation. Peritonitis. Worsening findings. Challenge. CT limitations. High suspicion. Missed injury. Management. Depends. Destruction versus circumference. Serosal. Reinforced suture. Small perforations. Primary repair. 1 to 2 layers. After debridement. Avoid narrowing. Multiple perforations. Primary repair. Okay if not too close. Many prefer resection anastomosis. Large injuries. 50% circumference. Resection anastomosis. Stabled versus hand-sewn equivalent leak rates. Surgeon preference. Hand-sewn often 2 layers. Single layer. Okay. Damage control. Rapid closure perforations. Resecting large injuries. Shock.
Resection without immediate anastomosis, highly risk. Temporarily, close abdomen, resuscitate. Reestablish continuity, second look OR. Colon and rectal injuries, most common penetrating. Rare blunt, mostly hematomasrosal tears. Mortality historically high, WWI 22-35%, mandatory colostomy. Contemporarily low as 1%. Classification, destructive versus non-destructive. Destructive penetrating, 50% circum, transection devascularized. Destructive blunt, serosal 50%, perforation, mesenteric devascularization. Pathophysiology, blunt course rupture, retroperitoneal perforation possible, fearing voice, peritonitis, free perf, retroperitoneal distal obscure, found laparotomy, CT limited, may show thickening stranding fluid tract, assess retroperitoneal carefully, triple contrast, TT debated, rectal evil, DRE, blood presence not confirmed, absence may rule out, positive deep repenetrating trajectory, B is further imaging. Indeterminate CT concern, exam under anesthesia plus rigid proctosigmoidoscopy, characterized destructive, 25% circum versus non. Location, relative peritoneum. Upper rectal ID'd laparotomy. Management.
Depends. Destructive versus non. Physiology. Historical. Resection colostomy all. Paradigm shift. Stone of Fabian, 1979. Primary repair versus colostomy. Lower infection. Primary repair select patients. Memphis. Experience stratification. Non-destructive. Primary repair. Destructive resection. Resection anastomosis. Destructive comorbid resuscitation. Citron diversion. Schema holds blunt penetrating, not impacted contamination. Distal resectional colonic anastomosis. Damage control laparotomy. Unstable. Resect destructive. Avoid immediate anastomosis. High leak. Abbreviated colostomy or discontinuity. Reestablish continuity colostomy. Second look OR. Controversy delayed primary versus colostomy. WTA bias. Ostomy shock. Comorbidities. Open abdomen.
Unanswered, roll diverting loop ileostomy after starboard drainage. Wound resolution to find rectal enema before reversal. Limited data routine, diversion drainage all. Recent evidence, extraperitoneal managed without drainage, just diversion. Intraperitoneal rectal injury found laparotomy managed like intraperitoneal colon.
Abdominal grade vessel injuries. Predominantly retroperitoneum, some mesenteries. Challenge. Massive blood loss compromises visualization. Mechanisms mostly penetrating. Blunt. Retroperitoneal hematomas, often secondary pelvic fractures. Evaluation. Initial recognition, often laparotomy penetrating. Associated significant ongoing loss. Instability. Delineation better after exploration exposure. Benefit 3D imaging, CT. Blunt vascular. Contrast, CT. Urgent laparotomy. Retroperitoneal vascular ID. Further ID depends hematoma location. Management. Penetrated retroperitoneal. Require exploration repair laparotomy. Basic exposure. Invarenal R. Renal hylomoperpate. Proximal distal control when possible. Blood vascular, not actively bleeding. Operative repair or endovascular. Retroperitoneal hematoma location. Guides decision. Zone 1 central. Aorta proxivisceral IVC. Requires exploration. Exception. Dark hematoma behind liver. Retrohepatic facing. Do not expose. Gently pack preserve tamponade. Zone 2, kidneys. Explore only if expanded going loss. Zone 3, pelvis. Usually pelvic fracture. Do not explore unless exsanguinating obvious. Genitourinary injuries. Kidneys, ureters, bladder, urethra, retroperitoneal. Major concerns. Bleeding. Urine extravasation. Mechanisms. Blunt. Renal laceration. Bladder rupture. Peritoneal pelvic tissue. Almost always a sock type pelvic fracture. Penetrating. All vulnerable. Many cause extravasation. Evaluation. Gross hematuria, most valuable screen blood to further evil. CT-IV contrast IDs, kidney adrenal injuries, suggests extravasation. CT, cystogram bladder injury suspicion. Male urethral injury, blood beneath displaced prostate. Retrograde urethroplasty before catheter. Penetrating. ID laparotomy or imaging. CT helpful back injuries, track, adjacent organs. Management. Laparotomy, penetrating retroperitoneum near kidney. Salvage dictated patient physiology. Ureteral. Primary repair to nephrectomy. Intraperitoneal bladder. Repair 2 layers of the brain bladder, fully sorbed pubic. Extraperitoneal bladder rupture. Only decompression. Urinary catheter. Cystography confirmed healing. Blunt GU. Mostly NOM. Kidney adrenal bleed, often self-limited. No ongoing bleed, more NOM. Deterioration, more laparotomy. Hemodynamic stability plus pseudoaneurysm, misangioembolization. Renal hematoma, blunt, laparotomy. Explore only if expanding. Injuries to the pelvis and extremities. Musculoskeletal majority trauma. Orthopedic commonest MTDB 2016. 31.66% upper, 40.09% lower. Low mortality, 45%. Significant long-term morbidity function mechanisms. Falls, MVAs. Evaluation. Exam ID, open fracture deformity, plain X-ray effective. CT complex pelvic fractures, characterization, ID hematomas. Active extravasation contrast, extremity exam, thorough vascular assessment, compartment syndrome, evil, vascular injury, unique challenge, coordinated approach, initial, fractures, increasing volume, compressed, binder sheet, reduced space, tympani venous bleed, ongoing instability suggests arterial angiography embolization. Alternatives, peritoneal packing, if endo unavailable, delayed, stabilization, pelvic ring stabilization, external fixed definitive repair, maintains reduction, limits venous bleeding.
Wow. We have truly walked through the immediate life-saving efforts and the complex decision-making in acute trauma management. But the journey doesn't end there, does it? There's a whole crucial phase dedicated to long-term recovery. What is the role of rehabilitation?
This raises an important question, and it's critical for elite professionals to grasp. While acute management is vital for survival, it's the rehabilitation process that truly limits long-term morbidity, shaping quality of life after discharge. Rehabilitation is often much longer, more arduous than initial hospital care, but indispensable for restoring function, allowing return to productive lives. The scope is immense. In 2013, 31 million non-fatal injuries needed rehab services, highlighting massive need beyond fatalities. Early mobilization begins immediately after acute needs met, often in ICU. Extremely important to circumvent deconditioning.
So getting people moving as soon as safely possible.
Yes, exactly. Muscle atrophy, joint stiffness happen fast. The rehabilitation team is multidisciplinary. Physical and occupational therapists initiate therapy, determine post-hospital resources. Case managers and social workers identify inpatient-outpatient resources based on recommendations, coordinating complex transfers, ensuring continuity. This early engagement is paramount, expediting referrals transfers, preventing delays. Specialized centers benefit certain populations, example, TBI, SCI. These cohorts have unique needs best addressed by specialized expertise, equipment, staff. Health systems committed to trauma care must prioritize supporting rehabilitation. It's a crucial aspect of long-term recovery. It completes the circle of care. #outro.
Wow. We have truly taken a deep dive into acute trauma management, from its wartime origins and the intricate dance of trauma systems, to the incredibly detailed and rapid interventions, and finally, the crucial journey of rehabilitation. It's a profound testament to organization under extreme pressure.
Indeed. It's a field that constantly evolves, driven by relentless research, military experience, and the dedication of countless professionals, all striving for that fundamental goal. Right patient, right place, right time, and meaningful recovery. The depth pushes medical science boundaries.
We've seen how organizations like the ACS Committee on Trauma standardize care, how injury scoring provides a universal language, how critical pre-hospital decisions are in those golden moments. We delved into damage control, revolutionizing surgical practice, prioritizing physiology, and we've taken that deep dive into specifics. Brain bleeds, spine fractures, complex chest and abdominal injuries, down to vascular details and organ repairs.
And beyond the acute, we've highlighted rehabilitation's indispensable role. Acute management ensures survival. Rehab limits long-term morbidity, allowing functional return. It's a testament to knowledge, organization, dedication, creating a true continuum of care, from survival to meaningful recovery.
You know, what really stands out is the foresight and dedication needed to build a system where, even in chaos, there is a plan, protocol, team ready to act with precision, supported by decades of lessons learned. It's profound human ingenuity and collaboration, always refining.
Absolutely. The level of detail for mastery, constant refinement based on data, the sheer volume analyzed from sources like NTDB, it underscores how complex and critical this field is. Understanding it like an elite professional means appreciating this interwoven tapestry of history, science, human endeavor.
So as you reflect on this comprehensive journey through acute trauma care, consider this. In a world where even a seemingly minor fall can trigger life-threatening events, how might the principles of rapid assessment, systematic intervention, and dedicated long-term recovery apply more broadly to other complex challenges? What other neglected diseases of modern society could benefit from such a structured, data-driven, collaborative approach?
It's an intriguing, powerful thought. The lessons from trauma prioritizing threats, acting decisively without complete info, leveraging specialized systems, committing to holistic recovery, are universally applicable blueprints for complex problems.
Thank you for joining us on this deep dive. We hope you feel more informed, equipped with insights like the elite professionals in this vital field. Until next time, keep learning, keep questioning, and keep exploring.